All right, we got a couple people on Zoom, so I'll go ahead and kind of get us rolling. All right. Well, so I know I'm using a microphone a little weird for the folks in the room because I don't think it's actually on, but this is how we're connecting with folks via Zoom. Tom, Grace, thumbs up. You can hear me okay? Wonderful. So welcome to our first Adler Society introductory meeting. It's good to see a lot of you in person here. We're just talking up front. I haven't seen some of you people in 2 years or something like that. So it's good that everybody's here. We're excited to kind of get rolling here with the year, and we can kind of big goals for tonight. Want to learn a little about the Adler Society. We're going to talk about some leadership opportunities, things like that. And we're also going to hear from Dr. Sweeney, and we have 3 residents with us as well. So it's going to be good kind of discussion tonight. So a little background though as we get rolling here. So what is Adler Society? What is and who is Dr. Adler? So Adler Society was established in 2011 in honor of Dr. Adler, who, if you, there's a really good kind of write-up on the website. So if you go to like the KUMC Orthopedics page and then look at the Adler Society group, there's a really interesting write-up about Dr. Adler, and it talks about his history, and it says that he was a, quote, Renaissance man with a pretty remarkable career in the Kansas City area in private practice and here at KU Med. And the mission of the Adler Society is pretty simple. We want to provide mentorship to medical students who might be interested in orthopedic surgery, as well as our orthopedic surgery residents here. So we're excited to have a couple of you all here with us tonight. Thanks for being here, guys. So, and then the goals kind of our society, as we would kind of expand that, is to provide that mentorship in a couple of ways, one of which is just trying to provide some exposure. So events throughout the year, we think that that is going to be an important way to kind of get students interested and help students to kind of better understand orthopedics as a field and kind of what that looks like as a residency and next steps as students in that way. We want to make this a membership organization. So kind of take a little bit different approach than maybe some of the other interest groups, in the sense that we would kind of like to see some consistency of our membership and that, with the fact that it's a society in that way, we should encourage students to, kind of stay involved and kind of be a part of the ongoing stuff here. And we think that will create some kind of meaningful events and also good, hopefully, relationships and good mentorship opportunities kind of moving forward here. So I wanted to introduce Adler Society leadership real quick, and then Dr. Sweeney, I'll turn it over to you after that. So just for food timing. So Dr. Sweeney is our advisor. I'll introduce him in a second. I'm Jack Ayers. Should have introduced myself earlier. Sorry. I'm a 3rd year here on the Kansas City campus, serve as the president of this group. Tom, you want to unmute? We can all hear you if you want to.
Yeah, I'm Tom McCormack. I'm sorry I couldn't be with you guys tonight. I'm glad you guys got to get together in person. Thank you to Dr. Sweeney and the residents. I'm down in Wichita, so.
He's using my Tom Superman Zoom can hear him. Or sorry, Tom.
Hello, everyone. My name is Karam Hamada. I'm a 2nd year, and I'm the representative for our class.
Grace, take it away.
Hi, I'm Grace. I'm outgoing leadership, but thank you for even putting me on the slide, Jack. I appreciate it.
It was awesome.
M4, I'm in Wichita right now doing a rotation as well.
I don't think Son is able to join us. I think I'd see her on here. So, and yeah, so we've got a small but mighty force here, and we're looking to add a couple more folks. We'll talk about at the end of the meeting, but kind of without further ado, I want to introduce Dr. Sweeney. Like I said, he's our advisor, amongst other many great accolades, assistant professor here in the orthopedics department, assistant director of the residency program, and he is a adult and pediatric musculoskeletal oncology surgeon and hip and knee reconstruction surgeon. Did his MD at Vanderbilt, residency at Emory, and fellowship at University of Chicago, and we're lucky to have him here at KU Med. So I'll turn over the microphone to you.
So just welcome to everybody. Also, thanks to you guys for coming. I think resident participation is big on this. So purpose of this is just kind of stay fairly, I'm like blocking half the room here. Purpose of this is kind of stay fairly light. We just want to introduce ourselves as a society, let you know kind of some of the things we do, and just to kind of dive a little bit more history into, how this started. It initially started as kind of a grandfathering process where one person was the president, and then they would pass it on to the next person, and we would do like a joint injection lab and a casting lab. And those were kind of the two events of the year for the most part. And then we really, what I ended up doing was feeling like we needed to empower you all as far as the students to come up with programming and make this relevant to what you need. And through that and through creating kind of executive council, we've had programming like Women's in Orthopedics panel, where we invited UMKC and the St. Mary's School, and we had female orthopedic surgeons from the community as well as here participating in that. We've started mock interviews for fourth years going into the process, and we've got faculty involvement with all of that. And we've expanded that into, post-match panels and et cetera, et cetera. So the point of it is to get you all in charge of it. And so that programming is coming from kind of a bottom up instead of a top down type of approach. And I think we've been pretty successful with doing that. And so those are some of the events. We still do injection lab. We still do splint lab. But honestly, it's I really like our other programming better because I just think it's a little bit more universal as far as not just how do you inject a joint, but how do I get into orthopedics, which is why we're here. And so essentially what I want this to be an opportunity for everybody is to, if you have, this is an introductory to Adler side, but also to orthopedics in general. There's a lot of people who probably don't know very much about it. So I would just want to open the floor to questions about anything. There's no bad questions. What's orthopedics like? What do we do? What's the training, et cetera? I've got other residents here that can give their perspective as well. So we'll just kind of open that up to the floor if anybody has any questions. Or if we have a set question, we can get that started. Yeah. Good. So as far as, I guess, what was the first part of that question? Sorry. What does training look like? Yeah, so orthopedic surgery is a 5-year residency program. About 80 to 90% of residents go on to do a fellowship, which are typically 1 year. A small number are doing 2 fellowships now. That's not necessary. And really, a lot of it is dependent on where and how you want to practice. I mean, we had a resident just last year not do a fellowship. And he's going to do great. He's actually stayed in the community, and he's going to be an orthopedic surgeon. So it's really what you want to do. As far as the training goes, it's not a lifestyle specialty, and I'm not going to make it pretend like it is. There's a lot of call. It's a lot of work, but it is really rewarding. You get to take things that are broken and fix them, and you get immediate reward from that. And in my case, it's more of a cancer slant, but the vast majority of orthopedics is a little bit more kind of broken and fix, or arthritis, and you fix that, or you get someone back to playing a sport with an ACL reconstruction, et cetera. So it is kind of this instant gratitude sort of thing. And it is a hard road, but at the same time, I think anything rewarding usually is. So it's just one of those things you just have to be comfortable with that. I guess I got to toss it over to Doug in terms of if you want to, Doug's one of our chief residents, and so he may have some good insight as well into residency.
Yeah, so residency, we're kind of all getting on the upper side of it. So you're 3 and 4 and a 5. It's 5 years. It's a very graduated experience, meaning, the first 2 years you're doing more, not necessarily grunt work stuff, but kind of basic stuff. You're managing patients, learning how to manage patients, and kind of starting to build a foundation of taking care of patients in the operating room. So that means, closing wounds, learning how to suture appropriately. And then when you get up to where I am, like today, I had 4 cases with one of our trauma staff where he wasn't even scrubbed in the room for most of it. He was kind of standing there heckling me. And, these are like real cases. We did tibial nail, bilateral distal radius fractures, did a bologna amputation, and then I can't remember what the last case was, but I also worked 91 hours last week. So, but that's like on the high end of the spectrum because I was on call 3 days and I'm on the trauma service. I was on the sports service before that and I was working 35 hours a week. So it all kind of balances out. But like you said, there's a reason orthopedics is one of the toughest residencies to get into. It's because everyone wants to do it, whether they want to tell you they do or not, because we have the best job in the world. So you get to take these people that are broken, you get to take these people that don't walk, you get to take people who have cancer, and whether you're not curing them, you're at least making their life better in some way, shape, or form. As far as setting yourself up for an orthopedic surgery residency, you guys are all ahead of the game from where I was. I bounced around to about 7 different things before I finally figured out I wanted to do orthopedics. So you're never too late. I didn't decide until like midway through my 3rd year. That being said, if you can get on research projects and stuff like that, it always helps. Something crazy like 57% of people who go into orthopedic surgery residency knew they wanted to do orthopedics coming into medical school. So you always kind of have to keep that in mind. It is competitive, but you know, if you put in the work and you get the scores and everything like that, you'll get to where you want to be, and it's rewarding. Like, there's a reason why I'm sitting here with a smile on my face and I worked 91 hours last week. Like, we love what we do, and I think these guys would echo the same thing.
And I would toss in, it's the 91 hours isn't an all the time thing. It averages out to less than 80.
I said I was 35.
Right, exactly. So we do follow 80-hour work rules. So I'm going to pretend I didn't hear that. But sometimes that does happen. But with that said, I mean, I think that you do average about, joking aside, I think you do about 60 hours a week. I think it's an average. So it's manageable. Yeah, so I would say it shouldn't dissuade anyone from going into it, certainly.
No.
And it is a competitive field, but I mean, again, I think if you dedicate yourself to doing something, I mean, we put students in programs, and we've been pretty successful with that, and we do not have a lot that go unmatched.
No, KU traditionally does very well.
Yeah.
Med school go matching residents.
Yeah,
Like last
absolutely.
year's match.
Yeah, it was. We had a great match last year. I expect a good one this year. Yeah, we ate last year.
And I mean, it was like,
And I think we only had 3 applicants before we expanded Adler, and then we had 5, and then 8, and then 16 this year. So I think we're doing something right.
I'm Jake Burlingmeier. I'm one of the 4s here. How many of you guys are M1s? A lot of you guys. How many are M2s? 3s? And 4s? Are any 4s here? Okay.
They're on rotation.
Yeah, I figured. So a pretty big mix of folks. I would say, sounds like it's more of a younger crowd here. I think, you know, thinking back to when I was a younger medical student, I think getting exposure to orthopedics early is pretty important. I did a lot of shadowing my 1st and 2nd year. And then really for me, it was the musculoskeletal system block that we had that kind of opened my eyes to orthopedics. I don't know, I just got it. I was good at it. And then I just kind of shadowed in orthopedics through my department, and found I really enjoyed it, and kind of pursued that relationship with that faculty member. He became my mentor. He was the old PD at the program I was at, and just built a really good experience with him. But I think just figuring out what you want to do earlier rather than later, I think is ideal, especially in orthopedics, because it's such a competitive match. Orthopedics is really hard to match into. But I think there are things you can do early on that can kind of set yourself up to be on the right path to match. But yeah, I just can't emphasize enough trying to figure that out early rather than later, because you can find mentors, you can ask questions, you can shadow, you can get some research done, and we can talk about all that stuff at some point. But I think that's kind of the biggest point I wanted to make.
So I think it is good to get involved early. I would say that I'm similar to Doug, though. I didn't decide on ortho either until I realized I didn't want to do neurosurgery. I think that's what I set in to do. And then I'm not talking bad about neurosurgery. It's a great field. It's just, it wasn't for me. And I didn't know that until I went through it on my 3rd year. And it's like, this just isn't what I want to do. But luckily I also did some orthopedics, and like, this is exactly what I want to do. So setting yourself up for success for an orthopedic residency is just like setting yourself up for success in anything. Do well. I mean, do well on your tests. So, although with that said, step 1's not even going to be scored anymore. So I don't know how we're even going to
step 2.
we'll still have step 2 until they take that away, which they will. I mean, that's just the way the world's going. And so, you know, it's one of those things where, you know, scores matter still. So work hard on that. Even though they say there's no class rank, there's still an element of, even though there's not a specific rank, there's still tiers of grades at most places. And there's also establishing some relationships for good letters of recommendation. So all of those, and then involvement in, research or academic endeavors. That's going to set you up. And also, I would encourage anybody here who thinks that they want to do orthopedics to keep your eyes open for other things. And that goes for advice in any field. I mean, you just never know that you're going to, go across ophthalmology and be like, this is so much better than orthopedics, or, and that's crazy and wrong, but no, but seriously, I mean, you keep your options open. I mean that because there's so much out there, and don't feel like you have to pigeonhole yourself into a single specialty right now.
Yeah, Marcus, I'm one of the third years. And so, no, I agree completely with what everyone said, but similar to what Jake said, I didn't know I was going to go into ortho until my third year, and it was February. It was the Super Bowl. And I remember that day. But oh yeah, that's me right there. Yeah. But yeah, so I actually thought I was gonna go in psychiatry, which is crazy, man. Just funny because I have no patience for patients. I mean, that's how I put it. But I didn't learn that until my rotations. But seriously though, what everyone said is really true. And one thing I advise you guys to do is develop a game plan. And a lot of that is through mentors. I did not have a good board score at all. I mean, step one for you guys, I mean, it's not even, it's pass fail, but traditionally I had, I always tell this med students because there's some med students who rotate with us and they're nervous because they have a lower board score, but I had a 220 on my step one, which is way below the average, for orthopedic surgery. And, I didn't have a mentor at my program at Indiana. And the mentor I had was the program director who told me not to go into ortho because I wouldn't match, because of my board score. And so I didn't really have a mentor, but I was thankful that one of my friends from high school who had the same board score as me was graduating Southern Illinois University, and he matched a Harborview. And he was doing very well. He took me under his wing, so I learned a lot from him. He got me prepared for my ways, because it meant everything to me to do well for my ways, because they weren't going to look at me otherwise. And all the tricks and trades he taught me, I did on the ways, and I shined on my ways. And that's why I had a good amount of interviews. And, Kansas was my number one. And I'm still to this day very thankful Kansas took a chance on me. And I'm sure Dr. Sweeney and the upper guys they're not regretting it yet. But serious guys, a lot of you guys, it's hard to know how, everyone says do research, do well in your your exams and so forth, but there's more to it too. It's how well you get along with the team, how well you do on your ways, how well you can interact with the attending and show that you're interested, pick up on the fine details, to show that you're coachable, to show that you're a team player, to stay a couple hours late to help the resident out when he or she doesn't need you to. It's the small things that really can make you outshine over another med student that has a substantially better board score than you. And sometimes it's hard to know those small tricks and stuff, but that's where the mentor comes in. So, any of us guys, any of the, Dr. Sweeney, anyone from our program, we're more than happy to help you guys. But there's a lot of small things that you guys can learn from any of us that can really separate you guys in a good way. So yeah, develop a game plan, and I promise you guys can go anywhere you want. Just look at how these guys just, matched last year. They did great.
So we do have a question from online, and this is from Liana Ochoa. What were some of the things you did in your undergrad medical education that helped you choose orthopedic surgery? I think it's just getting the experience is what I'd say, similar to what it is here. Just try to shadow, and you can contact people, you can contact residents, faculty. People are pretty open to you coming to their clinic or coming to the operating room, and that's how you do it.
Whether it's orthopedics or whether it's not orthopedics, you're just going to get on a rotation and you're just going to click with the people. It's going to make sense to you. You're going to enjoy what you're doing. And then before you know it, you're going to be like, oh, shoot, like the day's over and I'm like, I want more. So if that's psychiatry, or if that's orthopedics, it's like we talked about, don't pigeonhole yourself into something because you're like, oh, I want to do plastic surgery because I want to make X number of dollars, or I want to do neurosurgery because it has a prestige. Like whatever you do in medicine, if you do it for the wrong reasons, you are not going to be happy. So find out what you love. At least for me, it's like a big feel thing. It's just who you get along with, what you enjoy doing, and if it makes sense to you, and if you can see this being something you do for the rest of your life. So when you figure that out, yeah, then it's getting more experience with it, getting hands-on with it, building mentorships, doing all that stuff. But I think if you can take one thing out of this, it's like for you M1s, M2s that are here right now, good for you for like getting ahead of the game and getting ready. But like, don't sit here and be like, before I get on any sort of rotation, I'm doing orthopedics. Like I know 100% I'm doing orthopedics. I hate medicine. I don't want to do internal medicine. Like that's lame, right? Like maybe you'll get on it and you don't really like internal medicine, but maybe you like GI or something. You like doing procedures, and so you can do little procedures, and you really the GI system and all like whatever that all makes sense to you. You're like, oh no, I already set myself up for doing orthopedics. Well, you can always change. Like if you go into orthopedics for the wrong reasons, you will not be happy. If you go into anything for the wrong reason, you will not be happy. So
Yeah, Hossy's preaching. I mean, that is so true. All my med students, all my friends like try to pigeonhole me from start because I was like this dumb football player that got into med school, and they're like, "Oh, you're for sure you're football. Oh, you're doing ortho." I'm like, "No, I'm better than an orthopedic surgeon. Here am I now, right?" But you know, I went into every rotation ever, no matter if it was medicine, neurology, you know, pediatrics, whatever. My mindset was, I'm gonna go and pursue this field. You know, I knew back in my head it probably wasn't gonna be it, but my thought process was, at the end of the day, you know, you're spending so much money, so much time to become a doctor. If you become an orthopedic surgeon, you're more than a surgeon, you're a physician, you are a doctor. So putting in all the time you can during those rotations to learn everything you can, it's just gonna make you a more well-rounded physician. And I can't tell you enough for like, you know, us in a resident room and someone might have a consult and, you know, it might be something, some random zebra disease that you won't see a lot in medicine. It's probably Jacob Berlemeyer. This guy doesn't forget anything, man. But he'd be like, oh yeah, Marcus, it sounds like that one disease I learned in third year was, I'm like, how do you remember this? You know, but it's good. You know, you can really, you know, diagnose things that, you know, even medicine physicians might forget, you know, and it's really cool to see. So you guys owe that to yourselves. If you're going to be spending this much time, this much money and effort, you know, approach every rotation like this is every day is your last. Like you're going to put as much time as you can to learn all the, you know, all the information and know the pathophysiology of everything. And by doing that and having a good attitude, you're going to find out if you fit in. And nevertheless, like even by doing that and have a good attitude, you never know how good that can come and what good can come from that. I had that mentality when I went into, you know, I had to do a PICU rotation. I hated it, man. We had a round for like 6 hours. I was like, come on, man. But the head of the PICU whole team, the whole floor was a really big name guy. And he liked me a lot and he knew I wanted to do ortho, but I put the time and energy and he wrote me an unbelievable letter of recommendation that I put on when I rotated for residency. And obviously it wasn't an ortho letter, but even throughout my interviews, many physicians mentioned that letter saying how unbelievable it was. And the guy basically said, like, the pediatric field is, you know, scared that we're not gonna have this guy and he's going to ortho. You know, obviously he's full of crap because I want to be, you know, I only can do ortho. But the thought process is you never know who can help you out. If you really work hard, if you really put the time and energy and really show that you really want to learn, not only will you find out if that's what you want to do, but you never know if that tending down road is going to help you. Trust me, it happened to me and I was mind blown by that. So always just keep that in mind. So.
I had a general surgeon write one of my letters. He tried to convince me to go into general surgery and obviously it didn't work, but he actually asked me to write. He asked me if he could write me a letter. I didn't ask him, he asked me. And he's a general surgeon and he knew I was going to do ortho. So, I mean, just to echo what Marcus said, I think you really got your clinical rotations, your third year are really, 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 really important. You want to try and do really well on those. And like Marcus said, learn as much as you can on each rotation, study, read. My mentor at Rush always said, you know, read. And then once you're tired reading, read some more and then read some more. So really you can't read enough. I think to answer kind of the question that was posed, kind of doing what you guys are doing now, I got involved in my kind of Rush ortho interest group, essentially what it was called, very early, like you guys are. And I think that kind of set the stage for me to kind of go on the orthopedic path because I kind of had an idea I wanted to do orthopedics kind of when I came into medical school, unlike some of the other speakers up here. But you know, I got involved. I started doing some splinting labs and some injection labs and shadowing some of the physicians. And then I built those relationships. And I think that, and then I got involved with some research with some of the residents and fellows that were there at Rush. And I think that kind of went a long way in kind of paving the way for me to match. But I think you guys are all doing the right thing by expressing some interest and kind of trying to figure out what you want to do.
Any other questions?
And this could be for anybody or everybody, but is there anything about orthopedic surgery that surprised you that you didn't learn like until you got into it and like started practicing?
For me, it was probably the call. I think there's kind of two sides to call. I didn't realize I was going to be this busy on call. Like, you know, you see call at your medical school program, and then it could be completely different than how it is elsewhere. Like, and like I said, call is kind of a two-sided thing. Like on one hand, yeah, you get run down and you're really busy and sometimes you don't sleep. But on the other hand of that, like you're seeing all of this stuff. And at some point in your guys' career, no matter if you, even if you don't do orthopedics, you're going to be on your own. And so you have to be comfortable with managing things that maybe other people didn't see in your field. So, and I think KU, I'm really happy I matched here. I think this is a phenomenal program. We're very busy, but we learn a ton of stuff. I kept track of all the consults I saw my second and third year of residency. Our second and third year, we take primary call, which means you hold the pager. And just at KU, my second and third year, I had 867 consults. And that was just at KU. That did not count my children's emergency rotations my second and third year, which I was even busier at children's than I am here. And so, plus I didn't count my
That was
intern
just
year
1
consults.
weekend at Grady.
Yeah. Yeah, Emory. But I mean, it probably would have equated to 1,300. But I mean, that being said, like when I get done, like I'll feel comfortable managing some things that maybe somewhere else that's another program didn't. So I think call was something that kind of took me by surprise, especially when I first started my second year. There's kind of a steep learning curve, but once you kind of get into it, you kind of get a groove and kind of build some momentum.
Yeah, kind of similar to that. I kind of saw this on my ways, but you know, the joke is, you know, for medicine, internal medicine, all they do all day is like they just dictate. You know, they do their notes, they see their patients for like 10% of the time, then they just dictate most of the times, and then they might see new consults here and there. And so I was surprised for orthopedics how much you do have to dictate. Not nearly as much as, or you know, as much as internal medicine. Obviously, we'll see the patients, wake them up, do our exam, and then we'll do a quick note. But in terms of call, I think that's where I saw was very unique. I remember rotating at Southern Illinois and seeing, you know, the new second year kind of struggle with, you know, holding the pager and seeing consults while dictating a full note quickly. And that really surprised me. It's like, wow, you know, I thought we just see everything and then it would just be like a paragraph or two and that's it. Like, no, you have to do a full assessment, full consult note. And I thought that was fairly unique. And I think it's really good, kind of echoing what Burlingmeyer said, but Kansas here, we're pretty busy on call. You know, we do a 24-hour call. You know, we don't do night float here. So from 7 to 7, you're on call, no matter if you're in clinic or, you know, you're in an OR, and you can see a lot of stuff. Trust me, man. You know, it's very busy. Sometimes, you know, but it's intermittent. Some days it's not too busy. It's just, that's how call is. But usually we're really busy. So learning the art form of multitasking, you know, learning the art form of which consults to see first, which consults can you wait till later in the night to see, you know, how many consults do you see first until you write all the notes down? You know, are you comfortable being 2 or 3 consults behind, or do you see those before seeing this other consult? You know, every resident has a different way of doing it. Every resident has a different way of dictating, or like how to dictate, how thorough to be, and so forth. But I thought that was something that was very unique to me. But I think it's such a good lesson to be learned, because if you can master having 15, 16 consults in a night, even more, but find a way to be caught up with your notes by 7 a.m., you can learn a lot from that, where then you can transition those type of those pros you learn from multitasking, and be able when you're attending to run 2 rooms. It's stuff you can learn so much from multitasking, of keeping so much information in your head, jotting down the things when you see patients, but not forgetting the history. I mean, there's so much I can go on with it, but I think that was the one unique thing. Is it's more than just seeing a patient, having your thought process and calling the attending and telling them this is what you're going to do. There's so much more to it, and I think that was one thing that I was pleasantly surprised to be challenged with. So.
What I would answer that, and we'll take another question after this, but I just very briefly, one of the things about orthopedics that'll surprise you is how diverse it is in terms of what you can do. The difference between what a sports medicine doctor does and what I do is 2 completely different specialties. I mean, you wouldn't even think we're the same kind of surgeon. And so you can deal with things that are a little bit more, non-emergent or quality of life, or you can deal with things that are very emergent or life-threatening. And there's a whole spectrum of surgeries that take 15 minutes on the hand to something that takes me 13 hours on a pelvis and spine. So, I mean, it's really a huge spectrum within the field. So I think we had a question back here. I think I saw a hand. No? Someone scratched? Oh.
I know that we have MSK night at JDoc, but within KU or orthopedics in general, what opportunities are there to get involved in with helping communities like that, or potentially going to other countries and doing kind of volunteer surgery?
I'm not sure as far as through KU goes. I'm not as familiar with the kind of undergraduate education to know if you can fit that in. But I would say any surgical specialty, orthopedics included, there's a huge opportunity to go abroad with it. Just a quick plug, I'm more of a believer in going abroad for education than necessarily operating on someone and leaving them with their complications. So I think a lot of that happens as well. And people feel really good about it. They go and slam a total hip in, they leave, and then the patient gets infected, and what the heck, what do you do then? And so there is a element of being cautious, I would say. But with that said, I'm not 100% certain. Like our residency program doesn't really have that. There are some residency programs that will have built-in opportunities, not necessarily specifically going abroad, but you'll have, say, a 3-month block of time for research, and you can also use that to go abroad. So it just depends on the residency program. But there's a big need for orthopedics, although orthopedics the best way to do orthopedics in countries that don't have the resources we have is sometimes not operating. It's sometimes splinting, and it's setting fractures, and it's managing infections, and it's doing amputations, things that you wouldn't necessarily amputate here. You try to do some heroic limb salvage, you wouldn't do that if you don't have the resources elsewhere. But you can really impact people's life in a positive way if you do those kind of surgeries. So there's definitely opportunities, but it's interesting how different it is than what you practice in the States.
And so this is totally a Googleable question, of course, but just for the purpose of the discussion, since you talked about diversity in orthopedics, would you mind going over just real quick view of the subspecialties that exist?
Yeah, so there's general orthopedics, but in terms of all the specialties, you're going to have foot and ankle. You've got sports medicine, and so that's predominantly going to be, your scopes and things like that, although it's a lot more than just scopes. But that's usually what you think of. And then you have trauma. So they're going to come, folks coming through the ED, predominantly fracture work. And then you've got oncology. That's a really small field. There might only be about 200 of me in the country. And so that's a pretty tiny one. And then you've got even subspecialties within subspecialties, but like shoulder, there's shoulder and elbow doctors, there's hand doctors, there's ones that just do shoulder through hand. And so that's kind of split up quite a bit. Microvascular surgery is part of that as well. So finger replants and flaps and whatnot, free flaps, free vascularized fibulas, muscle, things like that you'd think of as plastic surgery. Orthopedics does with microvascular fellowships. You've got spine, which, by the way, neurosurgery did not invent spine instrumentation. Orthopedic surgery did. They just let all their patients fall into kyphosis. And what am I missing? Joints, yeah, arthroplasty. So knees and hips and knees. And peds, thank you. And peds spine, it gets even more. esoteric. I mean, if you go to a large academic place, you can get really esoteric with it, but those are the main ones.
So just kind of touching off what you just talked about, academics, what are the different types of residency programs out there, and what made you guys choose the one that you did?
I mean, so you can really split it between academic and community, I think, for the most part. And there's, like everything, there's a lot of gray in between, right? So, I mean, I would consider this an academic program, whereas I would consider KU Wichita more of a community program. And there is not a negative to one or the other. Someone who finishes at a community program has the exact same ABOS certification that I do hanging on their wall. And so it really depends on what you want to do and where it's going to take you. So if you are interested in doing if you want a competitive fellowship and you potentially want some bit of an academic career, then pedigree matters. If you don't care about any of that and you're looking to go into practice, or you've got a spot back home that you think you can get back into, or whatever this is looking like, there's no need for you to be striving to get into the highest pedigree place you can find. And there's also kind of some personal desires and what you like. But even more than that, I mean, every program's going to have a different flavor to it. I went to Emory, so Emory is pretty academic, but we also had the largest county hospital in the Southeast United States in Grady. And at the time, I thought it was a great idea to go and take that much call. I don't know that it would. I would go to Emory again, but I just don't know that I would want to take that much call. But every program is a lot different, whereas other ones hardly take any call. So it's really depends on what you want and how the program feels to you.
Yeah, and I think even within academic programs, then there's blue collar and white collar programs. I consider us more of a blue collar academic program where we're more heavily focused on operating than research. Not saying that we don't do research, because you can sure find a fair amount of it here. But then, like, one of my best friends is at Mayo, and he probably operates half as much as I do, but he has twice as much time then for reading and research. So if you asked both of us to quote studies, he would blow me out of the water. But if you put us both in a room and asked us to do a surgery, I guarantee you I'd do it better than he would. So you kind of just figure out what you want to do and where you want to go. And yeah, I mean, some of those places you go to get the fellowship you want, but we get whatever fellowship we want here too. You just have to put in probably a little bit more work.
Separating between academic and community like Dr. Sweeney does. I rotated at a heavily academic. My home program was really, really, really academic. And then I also did an away rotation at a community program in Ohio that a lot of people probably haven't heard of. It's called Summa Health. And the residents there were the best I've ever seen, operative wise. I mean, there were 2s and 3s doing total knees in 35 minutes with the attending standing on the by the computer in the corner of the room. And they would do them consistently. I mean, it really kind of depends what you want to do. But yeah, I would echo everything as far as if you want to get a really prestigious fellowship, or you are really interested in doing research in your career, then I would probably go more the academic route. But needless to say, like, I agree with Doug, this is more of an academic place, but it's more blue collar. We operate a lot, and there's definitely research here. If you want to do it, you just got to go find it. But I think the biggest difference between a blue collar and a white collar is, research wise, is a blue collar, there's not as much research support, I would say. Like when I was in my medical school, which was highly academic, there were there was like 5 research assistants for one attending. He had his own research team. And they'll do all your statistics for you. They'll write your IRB for you. They'll do all this other stuff for you. And so there was a resident in my medical school. He was by his PGY 4 year, he had 320 publications just during residency. And that's because he had his MPH and he did all the stats for all the different residents. What's that?
How many of his publications did he read?
I don't know. But yeah, and I actually looked it up on PubMed. It's true. So yeah, for what it's worth.
Yeah, just being a dead horse here, but I think, just the easy way to think about it is the blue collar programs, more community hospital programs. They might not have the big academic names like Stanford, Yale, Harvard, whatever. you're more likely to operate sooner and operate more. And so you know yourself the best. I know myself very well. I need to see things a couple of times until I can really grasp it, right? So I needed to go somewhere where I was going to see a lot and they'll let me do a lot. And Kansas was a program for me. So I ranked Kansas 1 because of that. And even as interns here, I mean, you do trauma for 6 months essentially. And, my first day as an intern, I'm doing stuff in the trauma room, and so that was really big for me. But you guys have to know what's best for you. Look, if you want to go to like a more high profile program, that is more than fine. But the thought process is, if you go on these interviews, look how many fellows these programs have. The more fellows these programs have, the less they're going to operate. I guarantee you, because those good cases, if they have a hand fellow, let's say they have a trauma fellow, and there's a really good acetabulum case or some really hard case, who's going to get it? It's the fellow. And actually, I saw this at a program I rotated at, where the fellow in the 4th year kind of got into it because the 4th year was going into trauma and wanted to see this case, but it was the fellow's duty to do that case because he was the fellow. He was higher up the board. So just remember, if you're the type of person, and there's nothing wrong with that. All of our learning styles are different, but if you're someone that you can see something once and kind of review it one time and you can understand it, you won't forget it, then maybe one of these, bigger name programs are great for you. But if you're someone like me that needs to see it maybe a couple times or do it once or twice until you can, you hit that threshold, then I would highly suggest going more to a blue collar program where you get your hands dirty from, right away. Like he said, Suma Health, that's an unbelievable program. Akron General, just across the city, unbelievable program too. Very similar to, KU, where KU is best of both worlds. It's a blue collar program, but has academic name to it. But I can promise you guys one thing: if you get into a blue collar program and you're hoping to go to more of a white collar program, and now you're thinking, oh, I won't get into academics, or I won't go to a great fellowship, that's completely wrong. How good you become as a surgeon in your residency is gonna be dictated on who? Yourself. I promise you. How much time you put in, how much time you read, how much time you're gonna be putting into going into cadaver lab, and et cetera, et cetera. A lot of it's gonna be based on how hard you wanna work. So, for instance, my buddy at Southern Illinois is a very small program, match at Harborview. Doug Hasse is going to the #1 trauma program in the country for fellowship, so like these smaller programs can bring out, there's a guy at Wichita that matched at Vail for sports, which is almost impossible to get an interview there, So is it harder? Yes, if you go to blue collar program, but it's not impossible. So remember that. You have better hands than all those people too, so.
Same education. You just have to figure out what you want and figure out where you fit in, because you're going to spend more time with these people than, like, I see these guys more than I see my wife. So yeah, if you're not happy at work, you're not gonna be happy at home, and you spend more time at work. And then if you're not happy at home, your wife's not gonna be happy at home, or your husband, or whatever. And it's just not gonna go well. So it's all a fit thing. Like I can't stress this enough. You got to find what you want to do in medicine, and you got to do it for the right reasons, because otherwise you're not going to be happy. And you got to find where you want to go in residency, and you got to go there for the right reasons, or you're not going to be happy. My initial list for residency looked like, if you just walk down the Doximity list of rankings for programs, and then I changed it up at the last minute. I'm super happy that I did. So don't get caught up in rankings. Go where you want to go and where you feel like you're going to be at home.
Over the next 10 years. Oh, yeah, sorry. What were the where do you see like the biggest changes as far as like technology or procedures or stuff like that occurring in orthopedic surgery over the next like decade or so?
So I'm going to hopefully do a spine fellowship. I'm actually going to submit my application tomorrow. I'd say robotics, at least in spine, is a big deal right now. It's a hot topic at meetings. At every meeting you go to, there's always a zillion robotic talks. We have 2 robots here, but we're about to have 4. And it's all it's just like a tool. It's not the robot doing the surgery for you or substituting you. It's not like, what is that movie, iRobot? with Will Smith, where the robots are doing everything for all the humans. It's not like that. It really just kind of is more of a tool in your tool shed that you have, to use. But I think you'll see robotics, and even in total joints is now what's been around actually longer in total joints, but we're going to be getting some total joint robots apparently soon. So
Yeah, it's 100% robotics. I think the last like 15 to 20 years, implants have been the major revolution in orthopedics, and for like fractures and joints and stuff, the longevity and ability of the joints and the ability to fix fractures with different implants has kind of been the big thing. But from the next 15 years gonna be dominated by robots, and it's probably gonna be biologics and stuff like that, regrowing bone or, preventing arthritis and stuff like that. But yeah, for right now it's robots. And it's like, I was a huge robot naysayer coming into residency and then even early in residency, but they're super fun. Like doing spine robots with Carlson. And I mean, for me, it means like, pelvis surgery is big open surgery right now, where you make these massive incisions and put plates and screws and all that good stuff in there. And I think probably by the midterm of my career, it's gonna be a lot more percutaneous stuff where you're using a robot to make small incisions, and then you're having it help you guide your screws down these pelvic corridors and stuff like that. And so certainly helps patients. And in my opinion, growing up with video games, they're fun to use because it's almost like you're playing a video game, watching a screen and kind of getting tactile feedback and driving the robot.
Another question.
We got one in the back.
So we've established that orthopedics is the most fun specialty. But if you had to say something that was like either frustrating or that you wish you could change about your specialty, what would that be? And you can't say documentation.
I mean, it really is a lot of work, and there's no two ways around it. So, I mean, I have a great family. I've got 2 kids, almost 3, and I see them plenty, but not as much as say my parents saw me. And I think that there's a element of stress to it that is, and that's pretty much with any surgical specialty. It's hard to describe until you actually even pass residency. Honestly, I didn't feel it till after residency, where you actually have the weight of somebody's life and expectations on your shoulders is a lot. And sometimes you'll see some people respond to that by being jerks in an operating room, I think, which is not, there's no excuse for that. But I think that's what you're seeing is a manifestation of that stress. It's a stress on their time, and it's a stress on just doing something that is high risk. And so I think that that's the one thing that would be a detriment is it's hard, it's hard. It's hard on your time. It's hard on your emotional well-being at times, even though, I mean, I love what I do. So, I mean, I'm emotionally great, but there are times when it's difficult.
You give up a lot, right? Like it's 5
Give up your
years.
20s.
Yeah. Like I went straight in, and I'll be 31 when I'm done.
Not completely. I had fun in residency.
Yeah, but like
But I also-
my friends are all taking trips places because they make more money than me, and they have like 3-day weekends whenever they want. And they're like, "Hey, can you go?" And I'm like, "No, I'm on call that weekend, and I'm operating till 4:30 in the morning with Marcus because he likes to make me busy when I'm on call." Yeah, right. Learning opportunity. That was a good case. But no, yeah, like beating dead horses, but you got to do it for the right reasons because you're going to give up a lot. I mean, you'll be rewarded for it through kind of seeing patients have good outcomes, and financially you're going to be rewarded for it. But man, in the end, it sure doesn't make up for it if you don't love what you do.
Yeah, I would just echo all that, just the time commitment, calls busy, but like I said earlier, you learn a ton, and you're going to be all of you will be on your own at some point. Even if it's not ortho, but when you get out, you want to go to a place that you're going to be well prepared to handle whatever comes to your table.
Yeah, no matter what you do, you better be all in. You are a physician. You're gonna be managing, people and the issues they have, the comorbidities, and you want to make sure that whatever you decide to do, you are all in, and whatever it takes for you to become the best physician, you need to do it. If you do orthopedic surgery, you're going to spend a lot of time away from family and friends. And I really encourage you, if you decide to do orthopedic surgery, just don't be the resident that's always, at the end of the, you come home at 8 p.m. and then it's Wednesday and you're just like, oh, I'm tired. I'm not going to study. I'm going to hang out with, my friend. Like, you should be studying. Always be reading. It sucks. I'm here by myself. My girlfriend's in Denver doing residency. My twin brother's traveling around the country doing whatever he's doing. But I could easily see more friends. I can easily have people come visit me, have my parents come visit me, drive out back to Wisconsin if I wanted to. But most weekends, if I'm off, if I'm not on call, I'm studying the whole weekend. I will go out here and there, with my friends here to take a break. But do I want to? No, of course not. I want to go out, man. Like, I like meeting people and stuff, but it's what I need to do to succeed. And that is something I'm okay with. So again, we are beating a dead horse, but I promise you, I know residents around the country that go into orthopedics and they're not all in, and they find out how much time and effort they need to be away from the family and friends to become good. And it doesn't turn out well. Okay. You'll be very unhappy. So you have to be okay with the sacrifice. That's like anything else in life. If you want to do something that, requires a lot of sacrifice, you better be okay with it, and not even okay with it. You better love it, So just make sure that's what it is. It's a lot of work.
Do it anymore? Well, you don't just go get to start a anesthesia residency in your third year of anesthesia. You start all over again. Right? So make damn sure it's what you want to do, whatever it is.
It's okay if you switch. I've
Just
also got
saying.
some buddies who switch. They're doing great.
You can
They're doing
switch.
fine.
People switch. People switch. I just highly advise not.
One thing I think people come into residency from medical school and they think, wow, I'm a doctor now, I'm a resident, I don't have to study anymore. But I think it's the exact opposite. I think, yeah, you actually, I think, are reading more as a resident, because you want to be prepared for your cases. You might come home from a long day on trauma, or, when I was on Dr. Sweeney's service on tumor, you'll finish finish your day at 6 p.m. You'll come home and then you'll eat dinner, and then you have to read for your cases the next day. Last thing obviously you want to do is not walk into the OR the next morning and not be prepared, because what are you going to get out of that? So just read and read. If you walked into his OR and he's like, okay, here you go. You have to kind of have an idea of what you're doing, otherwise you're not going to look great, and it's not good for you, and it looks bad on you, and you look lazy. And so, it's the reading kind of never ends for anybody.
There's other programs or other residencies where when you go home, you're done for the day. Ortho's not that. Your day just started, So like you can wake up at 5 or 4:30, round on your patients, go to conference at 6:30, and then from 7:30 to 7, you're 12 hours in the OR, and you come home. But especially when you're an intern or your second year and you don't know as much, and now you have 3 cases, let's say hand cases, Dupuytren's, that you don't even know what that means. You can't pronounce it, so you have to read up on that, right? And so you got to make sure that's one thing I always say, is that when you come home, when you're done with dinner, your night's just starting. So like, try to put, obviously sleep is very important. And you have to be able to balance. But at the same time, that's the one thing I thought was, unique about residency. Med school, you just watch lectures and you study. And don't get me wrong, I was always studying med school, but I would go to bed at like midnight, wake up at like 9, watch my lectures, because I didn't have to go. I don't know how it is for y'all. Do y'all have to go to class, or can you watch it online? Oh, that was the best, boy. I was watching 2x Speed, boy. So I would wake up like 9, make some eggs and cheese, and then, go to the library late, see all my boys, and just start studying. Here's, you might have to stay up till midnight, just make sure you're up for your, what's up for next day, but you might have to wake up at 4:30, to run on your patients, so, and that's not only ortho, like that's everything. Even intro medicine, there's a lot of residents that have to wake up super early to prepare, and that's just residency, man. But just always remember that. But at the end of the day, that's what you guys want. You want to be pushed. I promise you. If there's a residency, no matter what you choose, that is like telling you, oh, it's chill here, call is chill, run away. I don't care if you're in a suit, run 4.40, run away from that, because you want a program that is going to push you, emotionally, physically, intellectually, because that's the only way you can be the best you can be is when you're pushed. That is the best as you will as a physician. So
I'll temper it a little bit just because
Yeah,
you guys are
I
in
don't
the
want
thick of
to make it
Hold
seem
on a
like all
second.
we
So
do is
you
read.
guys are in the thick of the residency. The residency's hard. My life's awesome. So like I go home, I play with my kids by about 5 o'clock. Usually I have dinner with my family. We go on nice vacations. We, got a nice house. I mean, it's a good life.
Oh, our lives are also better than his life.
Yeah.
That's true. It kind of gets better as you go up.
Yeah.
So I mean, yeah, it's a little doom and gloomy here right now, but honestly, it's not. It is a very, very doable thing. It's a great specialty, and it's like I said, my life is actually
Yeah,
really
and the
good.
last thing I want to do is make it seem like all we do is orthopedics. It's not true at all. Like the four of the PGY4s were just in Boston. We went to Boston for a trauma course, and I mean, we had a blast. We went to Fenway Park to a Red Sox game. They played the Twins. I mean, went to the Oyster House there. Went to a few bars. I mean, we have a good time. I mean, we have a surprise birthday party this upcoming weekend for Tanner. So, I mean, we do stuff outside of the hospital. It's not just all 100% orthopedics. But I think, finding a good balance is something you guys have to figure
And you
out right
can't
away.
find a balance in orthopedics.
I've golfed every weekend this summer almost. I mean, it's like you can do stuff. And even when you're at work, like if you think about it, we get to do the coolest thing ever. Like we get to assault people's bodies while they're asleep with their consent, but then they all wake up and like they're better for it for the most part, right? Like you get to do really cool stuff. You take broken things
I
and
think it's
then
just assault if you do it. I consider myself a surgeon.
well, you take broken things or people who aren't doing well and you kind of in your little OR, you wrap up your package, you put a little nice bow on the top at the end with their dressing, and then you ship them off. And then, you get these happy patients for the most part coming back to your clinic in a couple weeks, and they bring you nice things like cookies and gifts, and it's fun. I mean, so yeah, even when you're in the thick of it, like there are fun things that you get to do. Like work is fun. Work is not work. Work is like enjoyable.
Other questions? Don't be scared from orthopedics because they have got doom and gloomy there for a second. Yeah.
What other specialties do you guys work closely with? And then which one are like each of your favorite specialties to like do combined cases on or just work with?
I'm kind of unique because I do some crazy things. So, I mean, I work with medical oncology, radiation oncology, pathology, radiology, interventional radiology, urology, vascular surgery, spine. So it's a little unique for oncology, I think, for ortho-oncology. But honestly, the favorite and least favorite would be vascular surgery. That usually means that something has gone down that shouldn't have. In the operating room because there's some sort of either an injury to or surgery right around vessels. And so that's kind of usually a sign of a difficult case, which that's why I do what I do. I enjoy that stuff. But I also have to say some of my most rewarding relationships are with our medical oncologists because it's kind of partnering up to figure out timing for surgery, if surgery is the right thing to do in somebody with a limited life expectancy or metastatic disease and things like that. So it's kind of nice from that standpoint.
You pretty much coordinate to a certain extent with every single specialty in the hospital. I'll say the most we work with obviously is anesthesia for obvious reasons, and they're probably our best friends and our worst enemies at the same time. But like we work with the trauma team, we work with the medical team for these people who are admitted to medicine to optimize these patients. We work with endocrine in order to optimize patients' bone health. Yeah, infectious disease is another popular one because of all these people who have infections. I mean, we work with neurosurgery. We work with plastic surgery for coverage of open fractures and stuff like that. Or if you need some soft tissue coverage for something that he's doing, where you're taking a big chunk of bone and muscle and soft tissue out. neurosurgery and us split call for spine, plastics and us split call for hand. I mean, so you're coordinating, I have the trauma list right now, so we have like 60 something patients on our list, but I would almost bet we cover probably not quite every service in the hospital that we are in discussions with, but 70-80% of them. I mean, so you get to overlap with pretty much everyone.
Other questions?
I have a question. Just we were kind of discussed this at the beginning a little. Obviously, standardized tests are going to be important, but with M1s and M2s, step one is pass fail. Obviously, you need to work hard, get the score you need. But what qualities are you looking for in someone in order to get an interview and then eventually get a spot?
That's a good question because it's kind of a two-part because it's getting an interview and then once you're in an interview, right? So once you get an interview, like there's a level playing field, I think for the most part, and that's even true now in terms of the difference between somebody who got a 260 and a 230 really melts away when you're talking to them face to face or seeing what they're involved in. I think a big part of it is just trying to become a helpful member of the team in terms of, I mean, the first 2 years is all just studying, right? I mean, that's what you're going to be doing so you can learn. But as far as your third year rotations go, you want to be a part of that team and you want to be able to have people want to work with you. You want to work with them. And it just involves, I mean, that's the best advice I can give you because that's when you're going to get your letters. That's when you're going to get people talking about you in a good way behind your back instead of a bad way behind your back because people talk. I mean, and so you want to be the one that they're like, wow, that person did a absolutely fantastic job and I loved working with them, So, I mean, really it's a lot of it is kind of personal connections that you make. And I should say professional personal connections that you make. It's not like someone really likes you, so they promote you. No, they respect you, so they promote you. And that's what you want.
I interviewed for our program last year. I think at the end of each interview, I always ask myself, can I see myself working with this person for 5 years of my life? And really, that's kind of the question I pondered when we kind of talked about the folks. But, obviously you want to be, I'm not the most personal guy, but, I get along with people. So I think, that's a big thing. Obviously, as it was mentioned, I think your scores and stuff are important. Obviously, with step one being pass fail now, really the purpose of step one was to compare apples to apples and not apples to oranges. I think what you guys will see is I think programs will become a lot more reliant on step two until that goes pass fail. I think that's how people are going to compare people to other applicants. And I think, as Dr. Sweeney said, I think once you're granted an interview, that means the field is level. That means you can be a resident there and match that program. You just kind of got to go take it. And interviews is a whole separate talk that we could spend another hour talking about residency interviews, but we can do that another time. That's another important part, but really you just want to get to know people and be personable and just do well in your rotations.
Let's keep moving it forward here, Doug, just so we can get more questions. Yep. I promise I'll let you answer the next one.
Oh, no, it's fine.
Next question.
On principle. So you say you read a lot, love it. What do you read? Is it textbooks? Is it cases? Is it like, and what's your favorite resource? Like, what's your go-to that gives you the greatest, efficiency, the greatest knowledge for, the least input of time when you don't have a lot of time to input?
That's a great question. So I always give a couple bits of advice on that. Number one, Ortho Bullets is going to be your friend. Orthobullets.com. You can make a little account and there's a whole bunch of useful quick hitter information on that. And so if you know that you're going to encounter something or you see something in an emergency department, it's really nice. It'll be like you look up the fracture, it'll tell you the surgical indications. So it's really that simple. We used to have, before Ortho Bullets, I would carry around like a handbook of fractures book and you'd have to like thumb through it and figure it out. And then Ortho Bullets came around and completely made everyone's life so much better. And then the other thing I would say is just general advice. And if you're preparing for a surgical case, Netters is not going to help you. Nothing looks like Netters. There is no color-coded muscle in the buttock. I can tell you that right now. But what would help you is a surgical text. So Hoppenfeld's is an example of an exposures. And so there's anatomy and then there's surgically relevant anatomy. And so learning your surgically relevant anatomy based on what surgery you're doing is going to help you a lot. You still need to know your anatomy just in general. And so if you're going into any surgical specialty, that's what separates a dangerous surgeon from a not dangerous surgeon, is knowing where things are. And that's also what, for a resident, that's what gets them, at least in my operating room, operating more. So if they don't know what's going on, I probe their knowledge. And if I don't feel like they have a good knowledge of the anatomy, I'll let them know I really would like you to, kind of work on this surgical approach, but I'm the one doing that surgical approach at that point. And I'll teach them while I'm doing it, but they're not going to be as hands-on until I know that they have a knowledge of that. And so that, from a medical student standpoint, I just want to know that you know where we are in the body. Like if I ask you what body part this is and you name something in a completely different body part, then I know you haven't really prepared for that case, right? And so that's would be my suggestion. So ortho bolts is number one, and then some kind of a surgical text. Hoppenfelds is what it's called, is probably a really good one. Yeah, those would be my two big ones.
If you guys go to the KUMC library, there's a button at the bottom that says clinical key. And then you can go, they have 66 dedicated orthopedic surgery textbooks that you have full online access to. Obviously, most of those are going to be like way outside of what you need to know as a medical student. But there's like Campbell's core orthopedic procedures and stuff like that. There's a lot of that where it's just like anatomy and dissection, and actually not Netter's anatomy, but like this is what it actually looks like when you're in the OR anatomy. So that's a good place to go.
I'd say don't obsess over the details. I mean, you can find a text on, you can find 5 chapters on anything that you want to find that on. What you want is a good overview of what's going on, and then the relevant anatomy. And I think those are the only 2 things I expect a medical student to know.
Yep.
That can't be overstated. The best surgeons are the best anatomists. That's one thing that I learned in medical school. I think you just have to, as you guys go, if you're going to do orthopedics, as you go on your ways, you start doing orthopedic rotations. Really, the only questions I ever got as a rotator were anatomy. Probably 95% of the questions I got in the OR were about anatomy, and the other 5% were, why are we doing this surgery, which you should know anyway, the indications for surgery. Who sings this song? Which I always get wrong. Just learn as you guys are, exactly. As you guys are going through your anatomy blocks. I don't know how anatomy works here at KU for you guys, but really try and pay attention to that stuff, because you'll forget it as you kind of advance on. But before any case you do, as you start doing away rotations, just really, really focus on that stuff.
Well, thank you everyone for coming. We'll just have a couple things we're going to wrap up real quick. These are our upcoming events we have this semester. We're going to be doing, kind of alluded to this earlier, a casting splint lab. We'll send you some information on that pretty soon. And then later in the semester, we're going to be doing a diversity and ortho panel. We're going to kind of alternate years on this. So it'll be diversity of different experiences, diversity of cultures, and basically everything that makes the people in orthopedics unique on that. And then we have our mock interviews for the M4s in the spring. Early in the spring, we're going to have those. And then a match day panel with the people that have matched. If you are interested in watching last year's match day panel, we have it up on our, just search Adler Society KUMC and then click on the website and you can see it on there. And then finally, we'll have an injection clinic. Anything you want to add, Dr. Sweeney?
I would just add that we also keep an eye out, because we are going to be looking for new executive council members. Is that coming up? Am I stealing your thunder?
No, yeah, you're good.
All right.
No, you're
I'll
fine.
desist.
So yeah, we're going to send that email out soon. We're looking for a KC 4-year student, M2 representative. And then we're just looking for anyone, M1 representative, whether you're not, whatever campus you're on, just let us know, at least here in Kansas City for now. And then just here, this is our information if you want to connect with us on social media. And then also,
What's that? Yeah, and I was going to say, so 2 things. One, you'll get a follow-up email from tonight as well. So we're going to get some feedback. So that's something we're trying to really improve on, is how can we improve on our events? And then the other thing is we'd encourage you, and so we'll send that out tonight. And then here we'll send out information about our application here coming up. But we'd encourage you to connect with us on social media. And we're kind of, especially on the Instagram page, we're doing a lot. Grace is a resident expert there. If she's still on, I don't know. But as regards to like putting up some even like practice test questions or doing some different content there. So that's been pretty cool. We did a resident spotlight, highlighting some of the new interns. So yeah, be sure to connect with us there and see what we can do. Join the beat if you haven't already. Be a good source of information there, and we can do some kind of RCPs and stuff through that. And then also, like I said, the KUMC Ortho webpage, Adler Orthopedic Society is like a subheading in there. There's some good information on there as well. So then in terms of logistics here, as we're wrapping up, grab if you and Crom, you got the list on your iPad, right? Yes. So if you signed up, grab a sandwich, and then for those who didn't, we'd appreciate it if even if you didn't sign up for a sandwich, because we have all of your emails who signed up, but for those who didn't get a chance to sign up, if you would just write your information down on here, we just want to kind of make sure we know who's here, so we can make sure we know who to get the kind of feedback forms out to and things like that. So otherwise, Crom, any other kind of logistical announcements?
Just for the people online, you can put in your emails on the feedback form we'll be sending out.
Yep. And Grace sent me, I got a list of the online folks, so we're good there. Just wanted to say thank on behalf of like Adler leadership and also just students in general. We appreciate Dr. Sweeney. We appreciate 3 residents here. We know your time is very, very valuable, but the fact that you chosen to spend your evening with us and teach us about what's going on is super important and super appreciated. So we want to thank you again for that.
Appreciate that. I just like to leave you guys with just kind of summary statement here, which would be that I guess I'm really happy to see this many people here, first of all, and I think orthopedics is a fantastic field. That's why I'm here. I would say that don't let, one of the things that almost kept me from orthopedics when is that I just viewed it as like a bunch of jocks and no offense, Marcus, a bunch of jocks that, they're just like the same kind of person that goes into this specialty. And I would encourage you that it's really not. I mean, there really is quite a bit of diversity in orthopedics, which is increasing by the year. And so just don't look at it like, well, I don't know, I'm not like that stereotype orthopedic. Well, I don't think I am either. And I know a lot of our department isn't either. So this is an open field for those that are interested in it. And it's a fantastic field. And I'm just happy to see everybody here. So thank you.
If any of you guys have any other questions, you can feel free to email us or email me. I'll give Graham my email or my phone number if you guys want to talk or get a beer or something like that. I'm more than willing to do it for you guys. And also this is, you don't have to worry about now because you guys are in obviously like first and second years, but maybe your third year. If any of you guys just want to see what a life is like on call, or even this year, because I'm a third year, I'll be done with primary call. If you guys just want to for a night to see what a night like is like on call, since I am primary, I'm on primary call, and you want to be with me just to shadow just how it is, seeing consults, helping me put splints on, I can teach you stuff just to kind of have an idea of it. That's always fun for you guys. There's a guy last year who did it as a third year when he didn't need to, just so he could kind of get some reps and see how it's like, and he did very well at a way that he just came from. He did very well. It's just more for you guys to see if this is, what call is like, and you can see some cool stuff. So yeah.
Shadowing and stuff is, we just unfortunately don't have a ton of it here as far as like clinical shadowing, at least in our department. But Dr. Brian Vopat, he's our head of research and he's a sports doc. I know they do like 6 med students every summer or something where they have this summer med student research program. So if you guys are interested, that's definitely something to kind of start seeking out, and he gets published.
Yeah, for the ones that application will come out in like January or February.
Yeah.
We'll make sure he gets it.
Yeah.
No, thanks, guys.
Okay, thank you, everyone.